Welcome to the Q and R's, question and responses for hips and joints. Now, there's going to be divided up into two different sections, one on the social media and the other is going to be on our site. So let's get into this. First question from Janelle, 1977, blessed. Any suggestions if I'm not able to get the trochanter support? Now, there's several questions about the trochanter support and belt, where you can buy them, what brand I use. Now, we get ours from Mayer's Distributing, okay, which is fantastic. But you can get a lot of them at sporting goods stores. And just make sure that they're thin enough. The ones that we use are only 4 inches in width. And they have a double pull. So one Velcro hits it, then the other two pull even tighter to lock it in. I've had patients that have used a scarf, okay, where they tie it really, really tight. Now, it's only going to be used when you're standing or walking. It won't do any harm if you were sitting, except it can compress the nerves on the side. But there's a number of different varieties out there, and they only cost around $10 to $15, and they're fantastic. But the key is when you're using a trochanter support, you got to be addressing the underlying cause, which is going to be pelvic instability. And so how do you correct the actual cause? You got to look at the biomechanics of the feet, the knees, the calf flexibility. You got to look at the lumbar, because there's never a pelvis that's going to have an issue if you have a good lumbar. And then also, if you have a lateral thoracic deviation, there's going to be that as a contributing factor. So you got to look at the entire structure. Even forward head carriage can flatten out the curve in the low back. So look at the entire structure, and as long as you're addressing all the underlying contributing factors and causes, then you should only need that belt for, say, a month and a half at the most. If you have a consistent trauma like past surgery or some type of scoliosis or some other kind of pathologies in the lumbar spine, you may need it longer. That's why, you may need to get a couple of these belts, but they are fantastic and they work really, really well. But you can use anything to approximate those hips. And once you find it, just get a couple of them. But once you stabilize that pelvis and you're addressing the underlying causes, you won't need it that long. They're really, really cool. But address the calf, foot biomechanics, knee biomechanics, everything. Question 2 from MRSN L. Willie 533. I'm 63. MRI of the knee shows torn meniscus. I had pain for over a year before the MRI. Unable to straighten the knee. Hip is off. Now suffering with coccyx pain. I'm unable to lie on back or sit. Seeing a chiropractor for 4 months with little change. How do I know if I need a trochanter support? Chiro's using decompression machines on hip and knee, laying flat on the back with knees up, more pain. Spend a fortune. Yeah, I'm not a big fan of those decompression machines. And the reason is, you're pulling it open, but if your knees, or if your pelvis is bent in a 90 degree where your knees are up on a platform, you're flattening out the discs in the back. And you need a lumbar curve in order for you to decompress that disc. So when you're accentuating the lumbar curve, you're creating a negative pressure on the front aspect of that lumbar spine. And that's going to move that disc away from where the nerve is, because the nerve exits on the back half of the posterior aspect. This is why we do all of our lumbar tractions with the patient face down under abdominal suspension, which is creating that negative pressure, which is fantastic, okay, to give the start. But also, decompression machines just pull straight up and down. It's called axial traction. The problem with that is there's never a symmetrical problem. You've got to have that force loading pulling apart, but you also have to have that lateral bending to ease that disc away from the lateral deviation, the sideways portion, to reposition that disc. And that's not the only part, because you've got to be addressing everything. And this is where a lot of doctors get confused. Back pain, they work on the back. Instead of, they're looking at why the problem is there. That's why you got to look at the entire structure, because Just forward head carriage can flatten out that curve in the back. Lateral thoracic deviation can do it. This is why pre and post x-rays are so vitally important. Now, to have a torn meniscus are a living tissue. They heal. So, and when you look at the knee joint, it has hydraulic. In fact, all the joints in the body are hydraulic. They need fluid. So under physical, chemical, emotional stress, the blood becomes thicker and it can't filter out through that synovial membrane to create the synovial fluid to give that cushion to it. This is why when you look at our knee and foot health videos, we talk about distracting that knee, using an ankle weight. And depending on your size, it could be anywhere between a 10 or a 20-pound weight, but you're not going to be lifting the leg. You're just going to be opening it up and dangling it. So it's ligamentous exercise. And what that does, that creates a negative pressure and it creates a little bit of inflammation at all the supporting structures, all those ligaments, and those ligaments connect the bone to bone. So you want to de-stress that joint out. That creates a negative pressure, increase in synovial fluid production. This is why we recommend the optimum is to do that leg dangling exercise with moist heat and an ankle weight. And just by doing that, you're going to have an instant relief. But make sure you're not lifting or extending that leg. Make sure you're just distracting it. But also, you got to look at the mechanics of the calf and the foot. In that calf muscle is a muscle called the soleus, and that's the soleus pump. So if you don't have good movement of that foot, good dorsiflexion, then you're not going to have good function of that pump, and then the knee joint is going to desiccate or dry up. Now, I'd recommend also to heal that meniscus is to increase the heat. Now, this is where a very, very simple knee support, and I'm talking neoprene material, just wetsuit material. You just want to increase the heat of that. You don't want any metal supports on the side to alter the biomechanics of that knee when it bends, because when that knee bends, it moves twice as much on the inside or the medial aspect as it does on the outside. So it's not just a hinge joint, it's a screw hinge joint, which is, phenomenal biomechanics. Now, the meniscus will heal. The outside edge of the meniscus has a beautiful blood supply. The center portion doesn't because it's under a compressive force loading. So a lot of doctors ignorantly will say that the meniscus doesn't have any blood vessels, so it can't heal. Well, it's avascular, which means where that compressive force load is, there isn't blood vessels, but it does get its nutrients. Those are living cells. The cells got to take in nutrients, produce proteins, eliminate waste products. So they're alive. It's not acellular where there's not cells. It's avascular because of the compressive force loads. So those cells get the nutrients through the synovial fluid. So increasing synovial fluid production, creating a negative force loading where you're opening up that knee joint to increase synovial fluid production, restoring the motion of the calf and the foot, but that all hinges on the nerves that supply that area. So this means proper decompression under abdominal suspension. So I'd switch chiropractors. I'm not a big fan of that decompression machine, but this is going to make a huge difference if you get under abdominal suspension where you're face down, creating that negative pressure on the anterior aspect of those discs to reposition that disc. And then the chiropractor, when you're in that position, it gives such an advantage because you get a chance to see how the muscles on either side of the spine are responding. Those are the paravertebrals, and those muscles are not under conscious control. So it'll indicate how that brain is viewing that area. So you got to change proprioception or how the brain views that area, because if you have symmetrical movement, you're going to have symmetrical force loading on it, and that's going to allow the discs to regenerate. And when you're in that face down position or prone position, the chiropractor has the ability to distract and laterally flex to work that tissue to get that disc repositioned, and he will know by the change in tone of those paravertebrals. Now, what we do is we do the same force loading when the patient's face down or in the prone position. We also do the same force loading of that lumbar and thoracic area in the side posture position without a lot of rotation, and then the same force loading when the patient's face up or in the supine position. So this way, when you're doing that same force loading, when that brain's in three different positions, you're changing how the brain views the body in space. So it sounds complicated, but really the bone's not out of place in the lumbar, and you're not putting it back in the lumbar. You're changing the position, motion, and communication so that that body can restore the normal motion. So under normal activities, then you've got normal function. It's amazing. Yeah. And never lay on your back with your knees or flat on your back with your knees up. That is reversing the disc. That is not good. It'll feel good while you're doing it because you're opening up the foramen or the holes where the nerves come out. And that is not good. I'm with you on there. That's frustrating. But make sure the chiropractor's doing pre and post x-rays. So they're documenting the physical changes on there. And typically people with decompression machines don't. Question 3 from Mary Miles 9922. I'm 63. I was told both ball joints have collapsed. Continual pain. Had back surgery 2 years ago. L4, L5, S1. Back still kills me. Can't afford replacement until Medicare. Any help available? Absolutely. Look at your structure. Okay, once you've had back surgery, you've completely altered the mechanics. And the area you're describing is right at the junction of the lumbar and sacrum area. Now, if they did a laminectomy or they saved it or they didn't put any metal parts in it, it's going to be considerably easier to correct. If they have bolted the lumbar to the sacrum, then that completely alters the biomechanics. So look at everything on that hip joint. Number one, your pelvis is going to be unstable for sure. And you've got to see what surgeons do is when they operate on a joint, they're using false information. And what I mean by that is if you say, ow, my back hurts, it hurts here, they're going to MRI there. And the MRI, you're done in the supine or laying on your back. And a magnet flips around your body, faces all the hydrogen ions in one direction, so the computer interprets this image. And inflammation can distort it, the body position can distort it. Then the doctor says, we've got the disc bulge. They operate on that area, but they're not looking at why that caused. And it's not from lifting or turning wrong. You've got to look at the entire structure. Forward head carriage can cause a flattening of the back. Lateral thoracic deviation causes a change in force loading. Past foot or knee trauma can alter how you walk. And knowing that the hips have been an issue, that means that your gait is off. So for sure, you've got an unstable pelvis. So you've got to get to a corrective chiropractor to look at the entire structure. That means from the pelvis to the cervical spine, way up there. I'm talking looking at skull reposition. Then you've got to take bending films of the surgery site. It'd be nice to have stress films of the neck area as well, but that means you stand up straight, bend to one side, bend to the other side, so you can see the mechanics. I can't tell you how many hundreds of patients I've looked at that have had surgery in the lower lumbar area, but there was really a lumbothoracic or, right at the junction of the rib cage and lumbar, a lateral deviation that was changing the force loading of that lower lumbar spine. And that was never addressed because it didn't hurt. 90% of the nerves that come off the spine, there's no pain fibers. So to guide where you hurt has the site of injury doesn't explain why it's there. So to damage a disc, discs are so tough. You got 80 interconnecting rings of ligamentous tissue. Like when I was doing human dissection, you could take a pen, which was a probe, and pass it into bone pretty good because bone is very porous and neat and can absorb shock. You can't beat it into a disc with a hammer. It's that tough. So to have a disc problem or a disc injury means that there had to be long-term abnormal force loading on that, which is absolutely the contributing factor. So once you've addressed why the discs in the lumbar were an issue, and that's going to be looking at the entire structure, then we got to start getting those hips healthy. So after surgery, you're for sure going to need a trochanter support. And this is going to be hugely important because that trochanter support is going to stabilize it. Then look at our knee and foot health video because we've got to distract that knee joint. You've got to start stretching the calves. You've got to start looking at any other causative factors that could be there. And if they did bolt that lumbar to the sacrum, you're going to need a sacral support for a long, long time, okay? Possibly forever. When people have had that lumbar bolted, you completely alter the biomechanics. And then that's an issue. But once you've addressed everything, then you can do a distractive force on that hip. That means you have got to stabilize that pelvis with a trochanter support. You put a weight on the hip, and you're just going to dangle it. Just dangle the leg. You're not going to lift it. You just want to create a negative force loading to open that area up. Then you put heat on the joint while you're doing that, moist heat. That's going to rush blood to the area because remember, all the joints in the body are hydraulic. And that means you need fluid. And if you put moist heat on the joint, that's going to increase blood flow to that joint and increase synovial fluid production. Now, you've got to address the other two stressors. You've got physical, chemical, and emotional stress. So we've got to change the sleep pattern. That's when the body regenerates. You've got to look at the emotional components, which is hugely important because that's going to actually limit how your blood is. Because if you have physical, chemical, emotional stress, the blood becomes thick and can't really filter into the joints as well as it could if you were under less stress. So this means juicing, blending, healthy diet. Look at the medications that can negatively affect the joints. And this is non-steroidal anti-inflammatories. Those limit the production of proteoglycan, and those are the building blocks of cartilage. So look at natural pain relievers like omega-3s, vitamin C. Those are going to be fantastic because they're very effective at reducing it. But also look at just applying moist heat on the hip joint. Do not put moist heat on the spine. That's going to be a negative because you're going to have, from the altered mechanics, you may have swelling of the nerves. And you're going to have guarding muscle spasms back there because those muscles are not under conscious control. So if you put heat on there, it's going to relax the guarding muscle spasms. And what the chiropractor is going to see, and this is why one of our 7 questions to find a good chiropractor is, do you work on post-surgery patients? Because this is more common than you could imagine. You're talking 70% of surgeries start to fail within the first 3 to 5 years. So the chiropractor has to address post-surgery, where you can't work on the surgery site, particularly if there's bolts and screws, but you can work and you have to work on the area above and below that surgery site. And just replacing the hips doesn't address the underlying cause. By addressing the entire structure, addressing the physical, chemical, emotional stress, changing the biomechanics of the feet and the knees, stabilizing that pelvis, distracting that hip joint, you may be able to avoid a hip surgery. Hips do not last forever. They're 10 to 15 years, and you're young. You're 63. Heck, I'm 63. You've got to be, if you do not want to have that fake hip wear out in another 15 to 20 years, if we can regenerate it, that would be much better. So there may not be a surgical solution. There may be a natural solution. So get to a good chiropractor that's going to do before and after x-rays, and they're familiar with post-surgery, and let me know how you're doing, because those solutions really, really work. Question 4 from Lynette Swanson, 3447. Hip pain for 4 years after a burst compression fracture of L1. And I now have 40-hour work week standing, walking, bending, lifting. What's the best choice to help with the pain? I also have a 13 to 15 degree scoliosis above that is acting up. Excellent. Okay, let's get you healthy. Burst fracture, super, super common in that area. But also, that's the area where the spinal cord ends. Think of this. Okay, you got an immobile rib cage on top of a really mobile lumbar spine. And the spinal cord ends at T12L1. Any pressure on that area negatively affects the entire gastrointestinal tract. And that's hugely important because this is how your body regenerates. The gastrointestinal tract, this is where neurotransmitters are produced. It's called the gut-brain connection. So it's super, super important to look at the health of the gut. And I know you're talking about physical pain, but we've got to look at the gut function. So we need to get stress x-rays of that area. Now, a compression fracture, what usually happens in compression fractures is the nerve exits the back half of the spine. So in compression fractures, non-pathologic, that means no infection, no other type of destructive disease, but this is actually a physical trauma. Typically, the back half of the vertebrae is still good, and the front part is compressed. So when I talk about gut health, we're also looking at blood acidity level, because if you have acidic blood, then the body's going to go to the bone bank to withdraw the calcium to alkalize the system. So ultimately, having the compression fracture, you got to look at, for sure there was a force loading, a fall or something that caused that force loading. But why did that area fail? Typically it's going to be a normal fall that you should have survived. And then ignorant people will say, well, it's because you're 63. No, 63 is young. I mean, ask anyone that's 103. They would much rather take 40 years off. Okay, so you got to look at the physical, chemical, and emotional stress. Do you have a problem with respiration, perspiration, bowel movements, and urination? If you're one bowel movement a day or every other day, that means the blood is going to be acidic. So ultimately, we've got to look at the blood health. We've got to look at the structure, knowing that you've got a lateral deviation of the thoracic area, that 13 to 15 degree scoliosis. What we need to do is get a stress x-ray of that area. That means you're bending from that outside curve, you're bringing into the convexity to see how much that thoracic area will move. And that's going to be where you're literally isolating that thoracic area, dropping that shoulder as far as you can, then taking an x-ray to see how much that scoliosis can reduce. Then you've got to restore the lumbar curve and restore the cervical curve, because the only reason that a person develops those sideways or lateral deviation is generally from a loss of the natural orthotic curves. And then you can start to address the scoliosis, you can address the cervical spine, and you can start to restore the lumbar curve, de-stressing out that area of the compression fracture. And it's going to be fantastic. Knowing that you've had that fracture, there may be pelvic instability, but also look at your gait. Look at how the feet are working. Look at how the knees are working. Look at how the hips are working. Stabilizing that pelvis is going to be huge, because bending, turning, lifting, walking is very good for you. Okay, it's actually movement gives life to those joints. But moving when you have altered biomechanics from that compression fracture is not going to be good. So you correct every area above and below. Even on a compression fracture, the chiropractor can do distractive forces, helping the discs above and below the compression fracture. Now, the worst I've ever seen is 11 compression fractures in a thoracic spine, and there's 12 vertebrae there. And some of them are old, some of them are new. But the key is, even on a compression fracture, you've got to do a little bit of distraction at that joint just to create a negative pressure. The patient will feel amazing because you're taking the pressure off of that. But with enough of that axial traction, you're going to allow fluid to get into those discs, because those discs get their nutrients from movement. That's why I say movement is fantastically good for you. And that is going to be the key to find a corrective chiropractor that can address the scoliosis, and somebody that's going to take bending films of that thoracolumbar junction to see what's working and what's not working, and then to restore the lumbar curve. You may not be able to put that foam piece that we have on our pelvic health video at that area because of the compression fracture, or you may be able to do it. And if you are, bam, okay, that's going to create a negative pressure on the front portion of that, moving that disc material that's damaged above and below the compression fracture, and that's going to be a huge difference. So, and you can get better, but you've got to look at physical, chemical, emotional stress, and that area is the most dangerous. D.D. Palmer, one of the founders of chiropractic, said the most important bone of the spine to adjust is D12. D12, that's what they used to call thoracic. They called them dorsals. But that is the end of the spinal cord. So this is a very important area that's got to be addressed, but it's going to affect a heck of a lot more than back pain. You're talking tissue production. You're talking anxiety, stress, and depression, because you're looking at gut function. Because if there's a compression fracture there, you're altering how the body can regenerate tissue. Now, if your question wasn't answered, please go to the Dr. B VIP. I'm going to respond to the rest of the questions. God bless you. Stay healthy, my friends. And there are solutions. The planet was made for you, and you're made in the image of God, image and likeness.